Namaskar. At the outset, I express my gratitude to the organizing committee of Innovative Physician Forums Medicon 2021 for giving me the opportunity for chairing an important session on clinical approach at geriatric OPD. Respected all, we know that due to various factors, management of geriatric patient is different from their adult counterpart. Focus of geriatric care is care, functionality, independence, and prevention of iatrogenesis. So keeping the focus in view, approach to geriatric patient is unique in different settings, so also in geriatric OPD clinic. So this clinical approach as geriatric OPD is very much pertinent and important. So speaker for this session is none other than Dr. Anand P Ambali, who is Vice Chairman of Geriatric Society of India, also Professor Medicine, Professor of Medicine at BLD, Deemed University, Sri B M Patil Medical College Hospital and Research Center, Vijayapura, Karnataka. He has established the geriatric clinic, dementia clinic, and immunization clinic, and recipient of State Award 2016 from Government of Karnataka for best services. He is fellow of ICP, GSI, Royal College of Physicians, Edinburgh, and scholar of Commonwealth Commission of UK, and for MSc in dementia for University of Stirling, Scotland. He has 70 publications and 3 fellowships to his credit, and is on editorial board of various journals and authored two books as co-editor and associate editor. Consultancy services to NPHCE, Tata Trust, Nightingale Trust, MPH, BLD, Deemed University, BLD, LAS, Institute of Nursing, Geriatric Society of India, District Committee of Prevention of Elder Abuse, and Group of Education and Research Geriatrics. So he is very much a dynamic leader in our Geriatric Society of India. Now, without wasting time, over to Professor Dr. Anand P Ambali. Dr. Anand P Ambali.
Thank you for those kind words, sir. Am I audible, sir?
Yes.
So thank you for those kind words, and I am aware that we are running a little late, so I will not take much of your time. So I think at the outset, I again congratulate the team IPF Medicon for the 4th successively conference, national conference, and I thank Dr. J.K. Sharma sir, Dr. O.P. Sharma, Dr. Manchanda sir, and all the team members for giving me this privileged opportunity. I bring greetings to you from the geriatric clinic of Sri B M Patil Medical College Hospital. And as rightly mentioned, since morning we have been listening to the deliberation, even older people have been given importance in their topics. And thanks Dr. O.P. Sharma sir for giving this lot importance of geriatric medicine at the national level. So thank you, chairpersons, for those kind words. And as you rightly mentioned, that approach to the older person differs from setup, either in OPD or an IPD, and in emergency setup in a home care. So in next 18 minutes, what I'll be discussing is regarding the principles in clinical assessment, so that we as a clinician, irrespective of our specialty, should be able to approach the older person in the right way. And there is another approach called comprehensive geriatric assessment, which we do at a geriatric clinic. That is the next step that we come across. So at the initial assessment in the geriatric OPD, whatever specialty you are practicing, so what principles we should follow, that I'll be discussing. So what should be our goal? When an old person comes to our OPD, what should be our goal? We should be preserve the function as it is or as it was before he has developed sickness. Always we should aim to improve the quality of life. As a clinician, we must know what are the various modalities of care that are available, like palliative care, rehabilitation, and when these can be incorporated in our treatment. The most important aspect for the clinician is to prevent a disability, because the older persons fear disability more than the death. So they don't want to be disabled throughout their life. So that is very important. And avoiding iatrogenic problems, especially for polypharmacy related problems, we should avoid as a part of our clinical examination, and we should always aim for a dignified death for a given older person. So why we should discuss about clinical approach? The clinical approach differs from center place to place and from countries to countries, and our country being having diverse population, and there are language barrier, educational barrier, and the amount of training that a clinician has undergone. All the factors play an important role when we approach an older person. So as of now, there is no universal geriatric assessment model. It is as we approach the passion that we have and the dedication that we can give for the older person in a geriatric care, it all matters. So nowadays, the older people are 5 to 10% of older people are seeking specialist or super specialist treatment. But again, what is recommended is, even our honor speaker from UK RCP mentioned that multiple specialties opinion has been taken, but again, the role of a family physician or a geriatrician is very, very important in preventing many issues, especially the drug related issues in them. So as a clinician, when we approach an old man above 60 years in our clinic, we need to have patience. Patience for what? We need to spend more time. The old person keep repeating the symptoms. I have seen, at least in my clinical practice, he repeats symptoms for the 5 times. The moment he comes in the OPD, during examination, after examination, when you write prescription, and even after completion of prescription, he is repeating the same symptoms, which are of lot of importance for him. And apprehensions. Most of the older persons, when they approach a doctor, they have a lot of apprehensions. What he will do next? Will he admit me immediately? Will he advise a big list of investigations? Will he do injections? So many apprehensions he'll be having, so we need to address them. Clinicians, of course, will have an observation skill that is very, very important. We should watch him, the moment, the way he walks, the utility aids that he's using. And third most important aspect a clinician must know is about the listening skills. The best geriatric practice is to listen to the older person, his history, past history, and what all he wants to convey. And as a clinician, one must know what is and what is not part of aging process. And we see that most of the symptoms in the older persons are being ignored by the patient first, second by the children, family, then the third doctor. This has to happen, then nothing we can do. No, we cannot ignore. And as a clinician, the message to be taken is we cannot do a complete examination in one setup, and rather we should not do also, because there will be fatigue in the patient as well and from the doctor. So plan our consultation in such a way that we take the important aspects as on now today, make a diagnosis, relieve his symptoms. Next time when he come, whatever is remaining, we can go on adding, as far as at least it takes 3 to 4 setups for a physician to know completely about the older person. So just I request all the honorable audience here to look at these following 3 items and register in your mind. Okay, so the color, item, and the animal. Now continuing approaches, the history from older person will be in 3 types. One, the history given by the patient itself in the presence of all the family members. Second, history given by the caregivers. It will be a little different. What is important for her or daughter-in-law will she tells first, but what the important for the older man, he tells first. And history in the absence of family members. This is very, very important. That is when the real history comes from the patient. Past history is always longer than the present history in the given older man. They will present with typical, atypical symptoms and the silent symptoms. So all that is important for a physician to know in geriatric practice. History of surgeries in the past is mandatory for us to know what all surgeries are underwent. And 3-item recall test. This is what I showed you, the 3 items just now, and what it should be done. I will come back to it. As a clinician, we must concentrate on the disabilities of the person he is already having. It may be in the form of vision, hearing, or use of aids, Parkinsonism, dementia. They are all now classified as disabilities. And mental health. Most important aspect, we should assess for loneliness, suicidal ideas, and depression. Earlier, we used to concentrate only on depression. Nowadays, loneliness and suicidal ideas are very, very common in the older people. And we should spend some time in looking at the medical records, what all he has undergone, tests, battery of tests, drugs, and all these years, what all he is taking. Without his knowledge, he'll be continuing so many drugs. So we should give some time for those. And of course, we should also ask for the immunization history, what all he has been against diseases which has been immunized. So approach to the older person in the history, we have to ask for his physical, mental, social, and spiritual aspects of his and it varies from person to person. It cannot be it is one size fits all. And we should always, as a clinician, try to address fearful in elderly. What is the fear that he's having? So that is very important. The symptom that bothers him most and the one that gives him a fear, that should be addressed by the clinician. At least ask him what is that is fearing you, and which activities has been stopped recently. This is very important for the clinician, because instrumental activity of daily living like gardening, riding, climbing stairs, going to shopping will stop first in the illness. Then activity of daily living like bathing, combing, then they will become dependent on the caregivers. So if the older person has stopped any of the regular activities, then there is a medical issue or health issue. We should also know the caregivers, who are the caregivers, and for their family members or the paid caregivers. Frailty and sarcopenia should be assessed in a given person. And most importantly, whether the elder person is being abused or not, that also we should assess, because that will help us to plan a treatment. Otherwise, n number of antihypertensive, n number of oral hypoglycemic drugs will not bring the sugar levels under control unless we don't address elder abuse in them. There are certain atypical symptoms. Few of them I am mentioning. So in older people, they may not directly come with fever. They may come with decreased appetite or increased thirst. So that suggests fever in the older people. And most of the older people, they come with giddiness and fall. And just you feel the pulse, it is either a SVT or 140, 160, and take ECG SVT, revert it. So most of the older people, they present in emergency department as an atypical symptoms, as well as in the OPD. So always fever, because of suppression of the hypothalamic system, they may not come with fever. All the clinicians must know about geriatric giants: immobility, falls, incontinence, pressure sores, intellect confusion, and iatrogen disorders, because these challenge our diagnostic skills. And any disease in the older person can be present with any of these giants. A person with myocardial infarction can come with falls. So that is what geriatric medicine is. And as a clinician, we should not look only at the fall and related complications. What caused the fall? We should think of that. And communication, as I mentioned, is the most important thing to be a successful medication and treatment for the older person. So get the person's attention before you start conversation with him. If he is using aids, let him put it on either eyeglass or dentures or hearing aids. Always face the person while talking, because that helps lip reading by the older persons. Speak clearly. Do not shout at them. They will get irritated. And most of the times, if the older person is short of hearing, you can use gestures to know what is happening. And most importantly, a clinician must know that the older persons seek privacy in their clinic. So this old man, 68-year-old man, he cannot hear and see. The only mode of communication was the touch. So the touch the part of the head, he used to say, I don't have headache, like this. And there are certain people who comes to say that I forget to tell what to tell next visit. I had symptoms, many symptoms in last 1 week, but I don't remember. So what we do in our clinical practice is we tell them to write the symptoms, or tell your grandson to write the symptoms that you have developed over the last week, and they come and show the OPD slip that they had symptoms problem. It is mandatory for all the clinicians to ask 2 questions, whether the patient tells or don't. Did you had a fall? That's very, very important, because most of the people try to avoid telling this. Second is constipation. Are you having constipation? Yes, these 2 symptoms, most of the people hesitate. Older people hesitate to tell, but as a clinician, we have to ask them and try to find the cause. Coming to the examination, vital signs. apart from those 4 vital signs which you have been taught, pain and delirium has to be assessed in all the older persons, whether he is in pain, his behavioral disorder is due to the pain, and delirium, acute onset confusion. So all these things has to be assessed in the vital signs itself. I quote a very beautiful quotation from Hutchison's 19th edition: "The bright and smiling face of an old lady may well mask considerable defects of memory and orientation." So this statement holds a lot of importance for all the clinicians, that we may miss dementia in the older people. She's just coming and charmingly smiling at us and say hello to you. What is to be assessed after a history and examination? So we have to assess the functional capacity, wherein we look for the activity of daily living, instrumental activity of daily living, as told you what activity has stopped earlier. Nutritional status, we do a mini nutritional assessment. Cognitive status, now just 4 days back, the ICMR NCT neurocognitive tool has been released by the Indian government for the Indian patients. We have to bank upon this. It's available on the website, and we have to use ICMR NCTB for dementia screening. If you are suspecting depression, go for a geriatric depression scale, and polypharmacy has to be addressed by the clinician, what is called as brown bag concept. Then in patients with IDL or IADL, I just ask the patient who use the turban, and I tell him to unfold and refold and put it on the head. So if he does it perfectly, his IADL is perfect. So a lot of skills are utilized, required for put a turban. And if he does that, you don't have to assess, go for the scales mentioned in the Western countries. Vision test, hearing, social commitment, spirituality, we have to involve in different setups as and when we meet the older persons. So get up, go test is to know the functional assessment. Again, the patient, make him stand on the chair, walk around 20 feet and come back. It should be within 20 seconds. If it takes more, he is likely to fall. This can be done in any simple OPD setup. Second is 6-minute walk test. This has to be again assessed for the functional, for the follow-up of the patient, especially in the patient with COPD. So we can assess the function, how long he can walk. Now coming to the care modalities, a physician must know the older people should have access to rehabilitation, palliative care, hospice care, respite care for the older people, end of life care, and allow natural death. This is a very important concept we are bringing now. So allow the patient to have all this access. First, the clinician must know what I can do after examination, after diagnosis, where should I refer to the patient. So that is how we have to look for all these modalities of treatment are the part and parcel of geriatric care. So what is important that has been highlighted since morning and in geriatric practice is we need to integrate. Alone, a single physician cannot manage the patient. So we need to integrate the clinical care, ENT, ortho, opto, psychiatry, dental, rehabilitation, nursing care, and even NGOs. That is what even the World Health Organization recommends. So as a geriatrician or a physician should be the team leader for this, and he manages all this problem, ensures that there is no polypharmacy, and whatever he can prevent, he should prevent a disability. That is very, very important. Now, coming to the end, I request all the audience to recollect the 3 items that you have seen 15 minutes back. So that is an 3-item recollect test. So if you have forgotten that, then definitely you have dementia. So you can go for that. This is how we do a clinical assess. We cannot tell the patient that I am now going to assess your dementia. I am now going to, this is a part of parcel. We show the 3 items initially in the first, and then in the again last, we ask him what is it. If he cannot identify 2 items in this, then there is definitely a dementia that is happening in him. So we have to assess. For again an ICMR scale, we can do an assessment. So the take-home message for a geriatric care in the OPD setup is, of course, it's a challenge. It is full of challenge to deal with elderly. You need empathy, you need time, you need patience, a lot of things. Older people are very smart. This is what I always teach my postgraduate students, that they are very smart. They have seen n number of doctors before he has come to you, and he can judge your knowledge only by body language. Only thing is they don't reply or they tell on your face, but they are very smart. They assess your depth of knowledge. So as a clinician, we must have patience, good communication skill, that is listening, and prevent as many diseases that we can prevent in them, or the complications of the disease he is having. person is having giddiness or vertigo, simple use of stick will prevent a fall in them. So we have to prevent. We require multiple setups in an older person. We cannot know the older person in one go. We have to call him repeatedly for examination and apply various modalities whenever indicated. Have empathy, and we should always prone for dignified death. And I pray, all the physicians attending this conference, say no to ageism. Don't deny any modality of treatment for them as far as just because their age is a number. And we have seen most of the older person have come out of the best treatment, and even the simplest of the simplest treatment that they deserve. So we should always practice dignified death in their end of life care and always say no to the ageism. So thank you all. Thank you for this privileged opportunity. And I quote said James Sterling Ross. He said, "You do not heal old age, you promote it, you protect it, and extend it." And we are all the part as a geriatrician and as a clinician. We must strive for this, whether it is an OPD, IPD, emergency, or in home care. Thank you all for patience hearing. Thank you very much.
Thank you very much, Dr. Ambali. Indeed, it's a very lucid presentation. Within this short span of time, he has covered huge things. This is required for all to know, I think. So in the chat box, there is no question. If anybody wants to ask any